Committee as a whole, Health and Public Safety, Mr. Amory.
Yes, we have a presentation for Medicare For All. Health Commissioner Seidel.
Okay. While you're setting up your laptop, I just want to thank everyone for designating this time to discuss Medicare for All. And I want to start with a quote by Gandhi who said, "It is health that is the real wealth and not pieces of gold and silver." And certainly that has been my experience as I continue to move through life. I agree with that statement more and more. Certainly good health is the foundation for us all to be productive, active members of society. Yet optimal health is elusive for many. Good health is not just a factor of the daily choices we make. Many, even those with good insurance, do not always have access to the care they need or can afford the medical care choices a diagnosis may present. Please understand that I'm not saying all people should have the exact same health status, but instead that social determinants must not be what holds individuals back from achieving their own personal best health. Medicare for All is a plan that addresses much of what is lacking in health care currently. Our senators and representatives need to know that there is local support for healthier communities. Most definitely, it is important to contact our legislators and let them know of our concerns one-to-one. But to amplify our goals for a healthy Kent, we need to join together with other cities who have already passed similar resolutions on Medicare for All. Having access to preventative and all realms of health care would lend itself to a healthier workforce, which would make for a stronger economy. If you're fortunate enough to have employer-provided health care, you still can understand that there are parameters set in place by that plan. What is in-network and what is not in-network can certainly influence your overall health. Personally, in the past other jobs I have held, I had the choice of a health care plan that had an annual $10,000 a year deductible. Myself and those of my families covered by that plan had minimal interaction with providers because even with the high cost of health care and procedures, it was not possible to meet that deductible. Every visit was out of pocket. Choice under these conditions was merely an illusion. I just want to say before I turn the podium over to Michael and to Max that I want to share a preventative measure that the health department is going to offer. We're going to have a flu vaccine clinic here at the fire department on October the 19th from 11 to 1 p.m. I just want to say that because the next city council meeting will be passed by the time that happens. So please look for your email, and we'll have both kinds of flu vaccine, high dose and standard. So please look for that email, and I'll turn it over to I'll turn it over to Max and Michael now. Thank you.
All right, hello members of the council once again. I wanted to thank you for providing the time for us to speak with the residents of Kent about something that as physicians we're very passionate about, which is health care. I also want to give a big shout out and thank you to Joan Seidel as well as the rest of the fantastic crew over at the health department because they've helped us a lot with this, and without them it wouldn't have been possible. So big thank you there. So today we have quite a bit to cover, and we do want to leave time for Q&A at the end, so we're just going to hop right into it. So starting out, we're going to cover why we feel it's important for cities like Kent to be passing resolutions about Medicare for All. And then we're going to jump into what the bill actually entails, sort of the meat and potatoes of it, and what the vision of Medicare for All is. Then we'll pause for some Q&A and have an opportunity to address some myths or misconceptions that people may have about Medicare for All. So I just want to start out by highlighting that local government resolutions actually have a large and rich historical precedent for organizing a national effort in making federal legislative change. A lot of our laws that are at the federal level started at the local level, and part of the reason that these strategies are so effective is because while individual advocacy is very important and definitely something that we encourage, having a resolution passed by an organization is a strong statement of support from a group of people. So it hits harder in some cases, and there are news articles written about it, and these are conversation topics that politicians and people who are making policy can have about it. So it sort of highlights it. And I want to say we are also encouraging people to take individual advocacy efforts through letter writing drives to senators, other representatives. So we are addressing that too, but this is part of sort of a multi-pronged strategy to help this legislation move forward. So some examples of resolutions that started locally and moved up federally are listed here. The 17th Amendment, which is obviously part of our Constitution, was initially proposed at the local government level. It took 25 states passing resolutions on this topic for it to be addressed federally. And now that's ratified in our Constitution. Another example is the Nuclear Freeze Campaign, which was an advocacy effort that started as a large grassroots movement, and its goal was to de-escalate the hostilities during the Cold War. And this took time, but as the effort progressed, it did lead to ultimately de-escalation. And I want to point out, actually, in 1982, the government of Kent passed a resolution supporting this. So it is something that the Kent government has done before, and more recent examples, such as talking about racism as a public health crisis, are other examples that we would include there. Both the women's suffrage movement as well as the civil rights movement also started as a large grassroots effort that then went on to have federal implications. So what are we looking like in Ohio currently? At this time, 6 cities and counties in Ohio have passed resolutions in favor of Medicare for All, and those are indicated by the green pins on that map there. But many other resolution efforts are underway currently, and as you can see, Kent is one of those locations, and we hope to be the 7th organization at the state level to kind of just express that we are supportive of Medicare for All because it just makes sense, and it's something that will help not only our residents, but all residents in our great country. And going away from governmental organizations, I do just want to point out that many medical societies and other organizations have already expressed their support of Medicare for All. Some of those are seen on the right side of the slide there, and I want to point out that several state medical societies have actually passed resolutions supporting the current bills that are underway. And we are hoping to present a resolution to the Ohio State Medical Association in the coming months. So just kind of to see what we're looking at here is that there's already substantial support for this, and we're just hoping that in the next few months and years to come that this is going to be a continually growing effort. And just kind of the highlight there, we've zoomed out, and we can see this is the national picture. There are a lot of pins on that map of resolutions passed and underway. So we're hoping to become part of a chorus of voices that is just really calling for healthcare as a human right. So now I'm going to pass it off to Michael, and he's going to talk a bit about the specifics of what the bill covers.
All right, thank you. And next I'd like to talk about the vision and some of the benefits of Medicare for All. Before we actually get into it, here's an outline of the Senate bill. We had to cut our breakdown of the bill to save time, but we can answer any questions about the specific language in our Q&A. We have slides at the end in our PowerPoint to discuss those. At the last City Council meeting, we testified on several examples of our health insurance system failing people both financially and with their health. And we even heard additional points of view from members of the council. So I feel like we're all in agreement that the health insurance system is broken. We understand there are a lot of perspectives on how to address these issues in our healthcare system. What we want to emphasize today is that a true Medicare for All system is the only way to carry our healthcare forward, because it is the only plan that satisfies each of these following criteria. For one, it expands Medicare to cover all medically necessary services, where other plans leave these essential services out to either be covered by private insurance or out-of-pocket expenses. And two, it actually eliminates out-of-pocket expenses with an exception to $200 for prescription drugs per year, while other plans will leave a lot more out-of-pocket expenses within Medicare, Medicaid, or private insurance. And then three, it is truly universal, meaning everyone is granted coverage under this plan, and no one has to navigate a fractured, hyperinflated private health insurance market. And when we mentioned that Medicare for All covers all medically necessary services, these are what we're referring to. Quite literally, the only thing I can think of that's not covered on this plan would be purely cosmetic plastic surgery. And then there are also many economic upsides to single payer or Medicare for All. in that it is funded by a progressive tax system based on the ability to pay, with a modest transaction tax on Wall Street, where fractions of a penny on the dollar go towards funding the program. And to clarify a little bit further, from a study in 2018 that did not include that Wall Street transaction tax, it estimated that the bottom 80% of income earners would save money under this plan, with the largest savings going to the middle class. And with the Wall Street transaction tax, we'd actually expect more savings across the board for all income brackets. And then next, the streamlined billing nature of this plan, that it's all single payer, through a Medicare For All system, that it would save immense administrative savings to the tune of $500 billion a year. And then it is important to note that in every other country that has a universal health care system, their federal governments are able to negotiate drug prices down. So they spend at least half than what we pay here on pharmaceuticals. And adopting this policy would finally enable the federal government to negotiate drug prices down for the citizens. Over here. To summarize the rollout of the Medicare For All plan, it is important to note that it includes a 4-year rollout plan. In these 4 years, all children and newborns would be enrolled into the program, and it would include a temporary Medicare buy-in and public option program. Medicare would be improved during these 4 years by offering coverage to dental, vision, and hearing services, which is not covered by Medicare right now, and people with disabilities that qualify for Medicare would be immediately enrolled without having to go through the mandatory 2-year waiting period. This policy would also provide 5 years of full financial restitution for workers in the health insurance system, because their jobs would most likely be lost with the inaction of this policy. And after the 4 years of the rollout, the full benefits of Medicare For All would take effect, which we have discussed previously. While I would prefer to have at least 3 hours to go through all of the benefits and the data that backs it up with Medicare For All, I'm really thankful to have a few minutes to talk about this in front of the council today. In the interest of time, I do want to just go to the next slide, because we understand that there are a lot of common talking points made against Medicare For All that have the council, that some of the council members and members of the audience may have heard. And I'd argue that these talking points are either misinformed or made purely in bad faith to smear the policy. And if you'd like any more information about these topics, we can toggle to these slides in our discussion for the Q&A. But I'll yield the rest of my time and open up the topic of our resolution for discussion and Q&A. Thank you. Yes.
Just an interesting thought. Do you think that Medicare For All would have an impact on your pay as a physician?
Yes, we can actually go to that slide, because that is a common myth that actually does get brought up a lot, and it's something that we've had to really educate our students on this issue as well, because that was obviously a concern of ours. But basically, you don't even have to take my word for it. You can take the word of the Congressional Budget Office, which is a nonpartisan federal agency that basically works through every piece of legislation that comes through Congress that deals with budgeting, and they do basically a budget analysis and see how it would affect costs across the board. And what it estimated is that providers, including physicians, would increase their revenue by 5 to 9% under Medicare For All than if there was no reform on the topic. So we'd make more money practically. And some scholars even project that we'd get a larger boost in take-home pay than that, because there would be a lot less burden of physician time spending negotiating with insurance companies or in private practice hiring billing clerks. This just leads to a lot more people seeking health care, which increases our revenue over the course of the year.
So just the administrative costs are likely to reduce.
Yeah, and actually, do you want to go to the next slide or the previous slide then? One with the hospitals. Yeah, and this is the one that we really want to point out in terms of the administrative cost. That's a really big burden. And this is, one example of a hospital system, but in the Duke University hospital system, which consists of 3 hospitals, they have a total of 957 beds throughout their entire system. So they're only treating less than 1,000 patients at any given moment. And they employ 1,600 billing clerks because they have to deal with several different health insurance plans and health insurance networks. And that is where the biggest brunt of hospital and physician burden comes from, is just trying to navigate all the different scattered plans that are out there.
So Can I ask a question? Jack?
Oh, yeah, go ahead, Roger, sorry.
Okay, no. So, play devil's advocate a little bit. What happens to those 1,600 employed clerks?
Yeah, so that is the part of the rollout plan that they would also be eligible for that 5 years of full financial pay. So, and part of that is it's fully encompassing. So if a person was nearing retirement, they would still get their retirement pay for like the 3 years afterwards. So they'd get all of their lost wages and health benefits. Anything that was under their, agreement of their terms of employment, they would be eligible to receive funding for.
Or could find another job?
Yeah, and part of the bill that's outlined, and this is something that's more going to be designed if it were passed, but it does say in the language of the bill that they would get preferential hiring if there were opening of positions to help, basically grow out the Medicare For All program a little bit. They would help them with jobs training as well and get them preferential hiring.
Gwen?
Do you have any information about potential economic benefits from a Medicare For All? Speaking specifically small business owners that are self-insured, maybe where one spouse is working for benefits only and the other spouse is working at a business. Do you have any statistics on how that might actually boost the economy, having owner-operated entrepreneurial endeavors not have to worry so much about health insurance?
Yeah, we don't have any specific statistics on that. Just more so the argument that we have is a lot of people that are either wanting to start a business but can't because they want to keep their employment for health insurance that they get through their provider or their employer. Helps on that front. But certainly, I think we could definitely send a follow-up email on that. But I'll pass it over to Max.
Yeah, and I'd just like to add, prior to medical school, I was working in a variety of part-time roles. And one of the limitations of part-time roles is you don't get health insurance in a lot of cases. So as a business owner, you're kind of put in a situation where you have to choose, do I want to have full-time employees who will become very adept at their job, and that's something more reliable that you can work with and more attractive for people that you're looking to hire. But under the current system, some business owners are forced to be in a position where they can only hire part-time employees. And that has some benefits in that you have decreased cost because you don't have to pay for their insurance, which if we had universal health care coverage, that would not be an issue. But the cost is it's much more difficult to maintain full-time employees. So I'd say that would be one potential benefit.
Further questions? John?
Yeah, I have a lot of concerns about this program, and a little bit of research. I was supposed to be getting a lot of information so I could ask the appropriate questions tonight from one of the hospital administrators. But I know Taiwan has socialized medicine and the single payer program, and they probably have the lowest administrative costs in the world. But as a consequence of that, it's bankrupted the government. So one question, I have that as a concern. And the other one is, I'm on a CTV newsline from Canada all the time, and right now, the residents of Canada, who is much underpopulated compared to the United States, and they have much less dependency as compared to the United States, the people are protesting, wanting to privatize the medical system because the system they have now that's so great is not working for the majority of the people. And the delays to get treatment, service, and everything else, it's frustrating. I had a fellow working for me this week, and he says it took him almost a year to get an MRI. And so that's nothing that I want to happen to my neighbors or my children, and I don't know how this differs. I know that the private pay or the singular pay system is appealing to me, where everybody feeds into a computer, but I'm just not real sure on the rest of it.
Yeah, no, I mean, I really appreciate your points that you brought up there. For one, I was actually going to think about bringing up the different countries, like the UK one. So it's important, I think, when we talk about measuring healthcare systems and their feasibility and their overall functioning to compare to countries that have a similar economic, GDP as our country. And when we look at studies that compare us to other OECD nations, like the ones on the screen there, we are ranked dead last in terms of healthcare functioning overall. So I do know, as like a global effort, there's a lot of countries that are under-resourced that are moving towards universal healthcare systems to help the citizens of their populations, but it's not a fair or it's like comparing apples and oranges for our healthcare system to theirs. If we want to have a healthcare system like the UK, where at least on the front up there, where they're like ranked in the top 1, 2, or 3, they have universal healthcare systems. So it's almost like to the point where you can start throwing out one country versus the other, and it's just something that we want to move forward through with that. And James, I don't know if you wanted to come up to address the second question.
Yeah. Hi. So I just wanted to respond just for a moment. But I hear a lot of concerns from people I talk to about our neighbors up north in Canada. So I definitely appreciate the concerns that you have from speaking with people. I would like to just insert a brief counterpoint, if I may, respectfully, which is that half of my family actually lives up in Toronto. And I have the unique access to someone that I'm very close to, my father, who grew up in Northeast Ohio and went to Kent State, and then eventually married a woman, moved off to a different country, whatever. But so he's had some comparative experiences, and we've had extensive conversations about it. And he makes a decent income up there, and so does his wife, and he loves it. And I think that's a kind of story that you don't often hear a lot because, frankly, when it comes to healthcare, people are often focusing on, unfortunately, negative experiences they don't necessarily want to ruminate on. But, he went to have his first child with my stepmother, and they went to the hospital. They were taken care of from A to Z, start to finish. Left without having a single conversation about billing, which is kind of a unique experience that Americans just don't have access to, that I think we should. Our citizens deserve the chance to actually experience full access to medical treatment without having this burden hanging over their head. And sometimes there are issues with scheduling. Wait lists are a thing that I hear often brought up, and that is a concern. But I'll say, for my own personal experience, I had to be put on, not on a wait list, but basically deferred treatment, because here in the United States, with a private health insurance plan, getting imaging is something insurance companies just don't like. It's usually a routine operating policy to basically have a blanket rejection for imaging requests of certain types, especially MRI and CT imaging, because they're costly. And for me, and this is kind of personal, but it actually, because I had to get prior authorization for a CT scan on my abdomen that I needed to have done quickly while I was still symptomatic, actually led to the delayed diagnosis of a chronic condition that I'm now dealing with that, isn't going to just go away. But when you have a private company who gets to just tell the doctors, no, you can say your patient needs this, but we don't want to pay for it, so we're going to make you play all these games for several weeks in a row. To me, that's morally reprehensible and not an experience that anyone should have to go through.
Well, I agree, and I've been very fortunate with the medical care my wife and my family have received, but I don't know which is worse, the insurance companies playing games with the doctors, or I don't know what the reason that there's delays in treatment in the North Country versus us. And then again, I would love to have the,
John,
Right.
John, point of order. I mean, this is questions, not,
Personal.
I mean, that's personal, and
yeah, I know, and so do you have any documentation or figures on how many people would be considered financially unable to pay for insurance versus, maybe other places, or?
Yeah. So there's kind of like two different ways I want to address your question there, and one of them is actually kind of to push back on the data behind rationing care in the U.S. versus other countries. While in Canada versus the U.S., and this was provided in your handouts prior, I'm not sure if you have a copy of it now, but we have several other copies, and I'd love to have them out of my folder, so you're welcome to it. But for one of them, it talks about rationing in hospital inpatient days per capita. How long per year, for each year, does each person get to spend in a hospital day? And the U.S. and Canada are actually tied at 0.6. But when it comes to physician visits, preventative care, seeing a primary care physician, the U.S. has, for on average per person, has 4 doctor visits per year. And in Canada, that number jumps up to 6.8. So just in terms of actual data behind the statistic, well, because I know a lot of individual stories can kind of contort the issue or conflate it, the data shows that we here in the U.S. actually have a less access to our physicians than in Canada. And another reason for that, talking about rationing health care, and this is a line that I did not come up with but had heard and repeated over time, is in other countries, they ration health care on need. So like in James's condition there, when they knew you needed to get a CT scan immediately to do the scan while it's symptomatic, they prioritize that, whereas other elective procedures do get wait time down the line to make sure that we're taking care of all the patients that they need to in those other countries now. In the U.S., we ration health care based on cost. And there's study after study, poll after poll that says 25% to 52% of Americans, depending on whatever poll, say they've avoided care or delayed care due to costs. So that is kind of the ball game we're playing, is do we ration care based on need, so we make sure we provide need emergently to anyone who really needs it, and the preventative care can be pushed off down the line, or do we basically keep doing what we're doing and say the bottom tier of society just doesn't get to see the doctor and has their conditions exacerbate?
Yeah, I agree, that's not good.
Yeah, thank you.
I would ask the question back. When it's your situation, do you want to be told that your condition isn't as important, therefore you can wait 1 year for your MRI, or are you going to have this utopian thing? Well, it's all, but I'll suffer for the greater good of mankind.
Yeah, well, I understand that concern, especially from like a member of the public. I guess if that was a hypothetical thrown at me as a medical student, I'd be able to rationalize, okay, I know this is something that I can get tested down the line, and it's definitely not something along the lines of like, oh, you have to get an MRI in 2 years. It'll be in 6 months or 9 months. And in the U.S., that is a reality today, where if you want to see a hyper specialist, you still have to wait half a year or so, or even longer.
I disagree with that, but the fact of the matter is, we're a society, an on-demand society, where we want our bagels delivered the next day by Amazon. And when you're told that your back hurts and you can't get an MRI for a year, and then I would ask the next question, like, who are you going to call? I mean, at least you can contest with your insurance company now. You're going to call the government? Who are you going to call in the government to contest your case of why you should have a priority?
Well, actually, that's a good thing you brought that up, and I'm glad you brought that up, actually, is because under Medicare For All, one thing that we haven't ever really addressed on these meetings yet, I don't think, is the in-network status. Under Medicare For All, every single hospital, private practice, doctor's office is in-network. So if you go to one doctor's office and in their hospital system that they have overbooked appointments, and they say, like, we would love to get you in, but we have to wait till 7 months from now, you can go to UH and see what their wait times are. In our current system, that is not possible because we have in-network status that is very confusing to navigate. So you always rely on your one primary care physician.
But that denies, that doesn't, I hear your point, and I don't want to get contentious, but it doesn't acknowledge the fact that who are you going to call when you have a problem? I mean, it's the government, right? It's an organization that has a 20% approval rating, and you're asking those people to run a medical system.
Okay. Well, I mean,
I'll just chime in on that. So obviously, this is like a very important issue, and thank you for asking these questions. But these problems are not absent in our current system, and we are making adjustments to try to address these problems. So there are specific positions that have been very recent developments in the past few decades in hospital systems where we have people who are made with the a position is made so that they can specifically advocate for issues like that. So you're assigned like a person, there are medical organizations known as accountable care organizations where they have their main function is to make sure that all their patients are getting these needs addressed. So it is definitely a valid critique that we do not want to be having people waiting long periods for this, but it's not necessarily a flaw with a general insurance reimbursement model, like a single payer one would be, but a separate issue that is also being addressed by healthcare providers and the healthcare industry in general. So it's definitely related, but it's something that's also being approached with other avenues other than solely insurance. So having those patient advocates employed by hospitals is something that could help with that.
And, I mean, sorry to like double up with a response here. I think there might have been a misconception here with when we talk about single payer or Medicare for All, it is just a public health insurance system. All of the health care is still managed by your doctor, still managed by the hospitals, so the government's never going to come in. They're not the ones saying, hey, on wait times, you, this one person in Ohio, you have to wait. It's not the government that's controlling healthcare decisions, and that's why we're actually pushing for it. Is because we think people that have medical licenses.
But the government is paying the doctors, and you're saying the doctors still control the situation. I think you're wrong. I think the system needs fixing, and there's ways to go about it. But I don't think here's the time to get back. I don't want to get back and forth. I think you guys have done a great job with your presentation. You're obviously very knowledgeable on it. I think the facts are contentious, and there's opinion and there's differing opinions on how the data is interpreted. And I think we should work towards a way to improve the system that we have, but jumping to Medicare for All is not going to be the solution, in my opinion.
Gotcha.
Robin?
Yeah, I think the issue that you're pushing, and correct me, this is a question, is how do we expand the possibilities of health care to the masses, so that more people are engaged in the process. What Garrett relates to, the cost issue, and the ability for those who already have to be able to then reach out and ensure that their care is taken care of and their issues are addressed, as opposed to your more general concept of the general populace and people who are currently outside of the system. How do we bring them in? How that can actually enable business, because it kind of reduces the cost factors on them, from what I can interpret. I see this all the time from I've heard that from businesses here in the States. We got to pick up the health care for all our people. It makes us less competitive in the world market. There are a lot of aspects, and Garrett, to your point, there are downsides, and there are downsides in everything we do. But the reality is right now what these young men and ladies are trying to accomplish is so that we lift ourselves up a bit, so we're able to reach out and assist those who right now are outside the system that are costing us a lot of money when they're not taken care of in a timely manner. because they're not going in. They don't have anybody to advocate for them. Nice, you can advocate for yourself. You've got the resources. Other people out there cannot. So my hope is that people will always be looking at the underbelly of this situation. And you and John, it's tremendous because you're very knowledgeable, and you guys deal with this on a basis that a lot of things you say are on target. We're not, I think a lot of us sitting around here already understand that there are challenges, but this is a better approach to dealing with the issue of the masses of people who are currently outside of the system. They're trying to create an ability to pull more of them in. There will be a benefit there. And we have to start looking at this thing as us against them and start looking at us all in it together. That's what I believe they're pushing. And that's my hope that we can support that.
Mm-hmm.
Thanks, Ron. Further? Okay. I don't know what.
Questions from the audience?
Oh, questions from the audience, comments? Back to council.
I'd like to make a motion. if
Okay.
I could. I'd like to make a motion that we pass a resolution to support Medicare for All.
Second.
Okay. Comments, Gwen?
I'm firsthand live day to day as self-insured. It's broken beyond measure. So you're speaking to the choir a little bit. I live it every day. It's my one of my most expensive bills as a small business owner, and that doesn't get me a whole lot. So anyway, I support this. I thought it was an excellent presentation. I learned a lot. I thought I knew a lot about what was going on, and I really learned a lot from it, and I appreciate it. I like this because I think it will perhaps make it a conversation and push it in our federal government in a way that they can see that residents care about it. If it doesn't end up exactly like this particular bill, but it will definitely push conversation and hopefully open some eyes to people who have federal health insurance from our federal government, that not everybody has that same insurance, and there are people who are suffering. So, thank you.
Heidi?
Well, I support this, and I agree with Gwen that, we have to have a national conversation. We did have one a number of years ago. It resulted in some improvements, tinkering around the edges, but it's really not, we're not there yet. And I find it very disturbing that we pay some of the most for health care and have the worst outcomes. That has got to be fixed. And prevention is one of the keys to that, and access to preventive services, to basic services that people tend to ration because it costs too much and it's going to eat into their deductible, and I can speak for that myself because I do that. Also, this is really hurting our healthcare industry in a lot of ways. I know that for working with behavioral health care. In fact, companies such as mine are no longer accepting private insurance because of the vast amount of unpaid debt that arises from that. The people that have government-funded health care do not leave us with that kind of debt load, and that reduces access for people. So that's very important. There's so many reasons. The innovation. For a period of my life, I was able to have health care that was not connected to a job. And I started 2 businesses during that time. I mean, imagine the innovation that would happen in the United States if these 2 things were uncoupled. That was something that only just recently happened in the 20th century, where they were put together. So this is a relatively new development where we expect our employer to do this for us, and it's breaking employers. It's breaking employers. So I think the conversation needs to happen. I think it comes from the bottom up. Are we ready for that? Well, we'll see. But we need to say that this is something that's really important to us. That what's happening now cannot go on as is without continuing to really hurt many people, especially the middle class. And the working middle class is really at risk for problems. So I support it.
Further? John?
I'm not going to support the motion, and that's not saying that our healthcare system needs a lot of work, because it does. But I hate to make a decision based on information from one side. I was hoping to bring some people to the meeting on council meeting that are much more educated with the medical than I ever could think to be, that have a different outlook on Medicare for All. All I know is, Obamacare came out, and there were people that wouldn't buy the basic policy because they didn't want to reduce their cell phone service or their cable TV service and spend some of the little bit of money that they made. They weren't rich, but they didn't want to spend that for take care of their own health care. And I can also remember my wife going through cancer treatment and heart treatment on not a real big income, and we were paying, I think, $2,400 a month for health insurance, but we were glad to do it because she's still alive today. And that was a big chunk to bite too, but I still respect the system that we have, even with all of its flaws, because my wife is alive today because she got the best medical treatment when she needed it, where she needed it. And so I don't know. I think there's ways that we can change what we have, improve upon it, which it does need done. And I don't think I could vote for something without hearing both sides of the story. So,
Garrett?
I'm going to vote against the measure also. I think it should be called mediocrity for all, because eventually that's what's going to happen. Is I think we're asking our elected officials in Washington who don't have the same medical system that we have. They have their own separate one. We're asking them to develop a system, and they can't do their existing job. The bureaucracy that's going to be created by having a whole nother department within the government, again, goes back to just larger and larger government and larger costs to all of us. And you can talk from everyone down from the lower class to the upper class are going to wind up paying more for the health care to subsidize and pay for that for a Medicare for All department. And there's never been a government organization that's ever decreased in size. I think you stifle innovation. You reduce the incentive for new drugs and treatments. You can't tell me innovation that's come out of the government. It comes out of a capitalistic society where money flows to where it's most profitable. And when you're letting the government decide what drugs can be researched, what money can be spent on research, you're ultimately doing a disservice to people that need not only the orphan drugs, but other drugs that can become available. You look at hepatitis. That was $60,000 a treatment, I believe it was at the time, and now it's basically cured hepatitis, and the cost has come significantly down. And that's what happens with all these drugs. You have innovation. The companies are allowed to make money for their innovation and the money that they put into the research and development of these products, and they get a patent for so long, and then before you know it, you have the generic equivalent for that. So I just think when you're asking the government to solve your problems, and there are problems, I'm not going to disagree, and I think that is not the answer to our solutions. And I would just, so I'm going to vote against it, but I would say again, it was a very well done presentation. Thank you for taking the time. I do appreciate what you had to say. I don't agree with everything, but I appreciate you taking the time.
Robin?
Yeah, what it boils down to me on is a right and a privilege. Whether or not people should have the right to health care in this country for all of its people or for some, those people who have the ability to access it, having had to deal with This is a great country. I go to dialysis 3 times a week. I would not be able to do that if it wasn't for the largesse of the people of this country in a system which picks me up every other day because it cares about the masses and not individuals. There are divots in the system for sure, but when we talk about innovation, this country will find ways to, if the system is in place, we will find ways to deal with those divots. We will find ways to deal with the deficiencies. But with people continually on the outside, it's not fair, it's not right, and it's not American. America is about uplift. It's about the ability for us to reach out and pull people up with us. For those who have, we have to be willing to sacrifice sometimes. And I just believe this is a right, and this is a time to deal with that. That these young people are standing up, and they're finding a way for us to do that. There's no in the world I'm going to vote against this.
Further? Roger?
That's pretty good.
What's that?
Oh, so-
Oh.
You know, I come at this a little differently. Being old, part of the reason that, in my opinion, that we're in this position that we are, a lot of it has to do with the, let's just call it the ability for large groups of people to negotiate contracts in the public. Starting in really astounded that we were at impasse, I guess, when I got to at my first school district, and they just threw in health insurance as kind of a, you know, a little sweetening of the pot, and it would cost virtually nothing. But think about this for a minute. So if there were only 100 people and they're going to buy health insurance, and it's not going to drive the price up, but when you have, let's say, 25,000 teachers in a particular area and they're buying health insurance, it became from a throw-in in the 70s as being a non-financial item to, by the time my career ended, I was sitting on the other side of the table negotiating with teachers. The main issue was the cost of health insurance, because the cost of health insurance was borne on 2 different groups at the time. It was the teachers themselves out of pocket that they had to pay per month for their health insurance, and the school district that had to pay the health insurance. So part of the problem is public employees actually drove up the costs by their participation in the insurance, because the insurance industry, and I agree with you completely, the most innovative group of people in this country from 1970 to the 2000s were the insurance people, who all of a sudden had an aha moment. Gosh, if we can get 20,000 or 30,000 or 150,000 school teachers, right, to negotiate health insurance, they began to see the massive ability to make profit. And so what happened is there was the balance between actual health and actual profit got kind of skewed. And what's tragic about it is we have some of the greatest medical people, the greatest doctors, the greatest types of medical innovation in this country, but in the end, profit by the insurance companies drives who gets served and who doesn't. And so I don't know that, I agree, Garrett, that government doesn't always do a good job. It's kind of like now, we're in the middle of a baseball, the end of the baseball season. You have some managers who have superstars in their teams who just got fired because they didn't win any games. So I think any program that comes up that's mismanaged anything the government comes up with, or anything that the private sector comes up with that's mismanaged, is doomed to fail, and it's going to be, I won't use the term, it's inappropriate in a large group. But bottom line is the bottom line, if this does nothing else, it sends a message that those of us who are fortunate, I'm blessed. I have, on Medicare, and I have a supplemental policy, I have the whole 9 yards. Even I have to wait for services, which is amazing to me. So I say, wait a minute, I pay all this money. But on the other side of the coin, we are the people who need to speak up and say there's something wrong with the system. And it's not because we're not being served. There's something wrong with the system because we have, and I'm a capitalist at heart, and I understand insurance companies want to make money. But when insurance companies are making the decisions about my health and the decisions on what I need for my health, there is a problem. So I don't know that anything will happen with this Medicare for All, but nothing else. We need to send a message that we're not happy with it. So unless everyone who's opposed to Medicare for All is willing to sign a petition, and say, we're not happy with how the medical thing's working, then I think we got to get their attention some other way. So that's my perspective on it. So I'm going to vote for it. Not knowing or not knowing what's going to come of it. I think it's the right thing to do to send a message that we're tired of the insurance companies and their excessive profits over the cost of, medicine.
Washington.
Okay. We have a motion. All those in favor?
Aye.
Opposed?
Aye.
Okay. Motion passes.
Thank you for your time.
Yes, it for Health and Public Safety. Moving on to Land Use Committee.
Well, this isn't as exciting as Medicare for All, but I call to order the Land Use Committee, and we have to repeal